Good morning, everyone. Today, Gilbert will be presenting the case and will be moderated by Professor Shabeer Ali, Professor Utpal Anand, and Professor Anand will be joining. Anand Laxmanan will be joining us shortly. It's all yours. You can take over now, Shabeer and Utpal.
Hi, Gilbert. Please proceed with your case.
Good morning, sir. The screen is visible, sir.
Yes.
Audio audible, sir.
Yes.
Yeah, it's good.
Good morning to respected teachers, seniors, and friends. The case capsule given to me is of a 47-year-old male. He is a farmer from West Bengal. He presented with chief complaints of epigastric pain for 3 months and multiple episodes of vomiting for the past 2 months. Going to the history of presenting illness, he was apparently well 3 months back when he started having mild intermittent pain in the epigastric region, which was not radiating anywhere. This pain was aggravated on fasting and it was getting better with antacids. After the onset of this pain, he developed multiple episodes of small volume vomiting, which was non-bilious, containing partially digested food particles. And the vomiting occurred 1 to 2 hours after the food intake. And this vomiting episodes have progressively increased in the last 2 months. Initially, he was vomiting only once or twice in a week. Now he is having 1 to 2 episodes of vomiting per day. And he feels the pain is better after vomiting. At present, he is able to tolerate only liquids. He 15 days ago, during one episode of vomiting, he had a blood tinged vomiting associated with black colored stools. During this time, he did not have any dizziness or loss of consciousness, did not require any admission or blood transfusion. He had unintentional weight loss of around 8 kg in the last 2 months. He has loss of appetite also. There is no history of any jaundice or fever, no history of dysphagia or regurgitation. He did not have any abdominal distension, bony pains, back pain, respiratory discomfort, hemoptysis, seizures, suggestive of metastasis. He did not have any generalized weakness or reduced urine output. No history of syncope and no history of blood transfusion in the past.
Hi, Gilbert. Yeah, just
Yes, sir.
after presenting this history, what do you think this patient, what are the symptoms at least you think which are very ominous? Or
Sir,
is it just a dyspepsia patient as usual in any gastroenterologist OP?
Sir, he's got epigastric pain and vomiting, sir. It started with epigastric pain, which happened more in a fasting state, which was in favor of gastric ulcer. Or,
I'm asking what are the ominous symptoms, so very alarming symptoms in this patient? Because he's presenting with something like a dyspepsia and some epigastric pain, all those things, which is a very common symptom.
Yes, sir.
So in this patient, what are the things you think very alarming that needs further evaluation?
The two things, sir. One is this progressively increasing postprandial vomiting containing partially digested food particles, and one episode of blood-stained vomiting, sir, which is in favor of luminal bleed.
Any other?
Anything else?
And this bleeding was mild bleeding, sir, because it was only blood-stained vomiting.
No, that you explained. We agree bleeding is a very ominous symptom. Any other? And vomiting is again, it's a significant symptom. Anything else apart from the whole history you narrated? If I ask you 4 symptoms which are very alarming in this patient.
Yes, sir. Yes, sir. Loss of appetite and loss of weight of 8 kg, sir.
Yes, very good. And what is more important in the beginning?
Sir, pain relieved on vomiting, sir.
Yeah, those things can be a part of a benign disease or malignancy. Short duration symptoms.
Short duration.
This patient has a short duration symptom, no?
Yes, sir.
And vomiting, as you said, bleeding and weight loss.
What is the age of patient?
47, sir.
So, what do you think? With this history, although you have not got physical examinations, so what do you think?
He's a middle-aged gentleman with a short duration history, uh, with futures more in favor of gastric outlet obstruction. Could be malignancy, and it can even be, rarely it can be benign also, sir.
What are the features which suggest it is a gastric outlet obstructions, and what are the features that differentiate it is benign or malignant based on this history?
Futures favoring gastric outlet obstruction are it is postprandial vomiting, sir, happens 1 to 2 hours at food containing partially digested food particle, and it was non-bilious. And features favoring malignancy are the short duration history, sir, and loss of appetite he has, and loss of weight of around 8 kg in 2 months, and also had one episode of blood-stained vomiting. It could be a
History of gastric outlet obstructions. Is there vomiting within 1 to 2 hours or delayed vomiting which are suggestive of gastric outlet obstruction? And what is pathophysiology of this vomiting, this type of vomiting in gastric outlet obstruction? That is classical vomiting that you can differentiate from other causes like gastritis or something like that. Because that is a 47-year is not old patient and is a very short duration of history of just pain abdomen and having vomiting. This may not be due to gastric outlet obstructions. So what are the features that suggest it is a gastric outlet obstructions? 1.5 hour, 1.5 hour. What is the actually? I want to know what is the pathophysiology behind this gastric this vomiting, which is suggestive of gastric outlet obstruction, not gastritis or other type of vomiting. Can you hear me?
yes, sir, I can hear you, sir.
Yeah, yes.
What
is the characteristic of vomiting in gastric outlet obstructions?
It will be a forceful vomiting, sir. Patient will have a lot of epigastric fullness and discomfort prior to the vomiting, and
no, there are different phases of vomiting in gastric outlet obstructions. One may be due to edema, inflammation, that is in initial phase. Lateral due to fibrosis and some cicatrizations. Then it will lead to gastric distension and atony. Then that that vomiting will be different from that of initial phase of vomiting. Then what is content? What is color of vomiting? Whether it is bilious, non-bilious, projectile, non-projectile. There are many things that are suggestive of gastric outlet obstruction. You cannot say directly that a patient is having vomiting 1.5 hour after the food intake, and that is suggestive of gastric outlet obstruction. That may be many causes.
Yes, sir.
So summarize what are the findings in this patient that are suggestive of gastric outlet obstruction?
Sir, one is it has partially digested particles, sir, food particles. That is in favor of outlet obstruction, sir.
It is bilious or non-bilious?
Non-bilious, sir.
Okay.
That's non-bilious and partially digested food particles.
And it is not. It is just 1.5 hour after food intake.
Yes, sir. It happens after food intake, 1.5 to 2 hours. That was the history given to me. And he has a sense of relief after vomiting.
And it is a partial gastric outlet obstruction or complete gastric outlet obstruction?
So the history-wise, he is still able to take liquids, sir. It was 1 to 2 episodes of vomiting per day at present. That means some amount of liquids he is able to tolerate, I feel, sir.
So this case suggestive of partial gastric outlet obstruction.
Yes,
and
sir.
it is in initial phase, means 1.5 hour after food intake, means it is in inflammation, edema. It is not actually completely blocking the lumen. So this can be implications in treatment, further treatment, right? So
Yes,
you
sir.
have to summarize in detail. It is a short duration and non-bilious and partial gastric outlet obstruction, not complete gastric outlet obstruction. Okay.
Okay, proceed.
Sir, okay, sir. So the treatment history is not provided. I presume that he has not taken any treatment outside for this illness, and he has come now only to the hospital.
So what treatment history do you want to know?
Sir, did he require any admissions for this vomiting? And did he require any blood?
Duration of history and partial vomiting. First time he came to your OPD. Then what type of treatment history do you want?
Sir, he has what type of medicines he has taken, sir? He has gotten better with antacids. And I want to know whether he has taken any PPIs and how long he has taken the PPI and how his symptoms after the treatment. And
Any
is there
drugs
any
which is associated with gastric outlet obstruction?
drugs? I am not sure, sir.
No, you are particularly asking about treatment history, so you should know some NSAID. These are the NSAID drugs which may cause partial gastric outlet obstructions also. Okay,
Okay, sir.
next.
And his past history, he did not have any similar illness in the past. He did not have any comorbidities. His personal history is sleep is normal, appetite is reduced, his bowel bladder habits are normal.
Just
He
wait.
is
What type of past history you want to know in this patient of gastric outlet obstruction?
is there any long history of epigastric pain and dyspeptic symptoms, sir?
What
Since
is suggested?
it
What it
suggests
is?
peptic ulcer disease, which is
Any other thing?
present.
Any other past history that can give you clue about current diagnosis?
Any
Only
past
that is of peptic ulcer. Yes.
yes, sir. Previous history of any interventions, sir. Any endoscopy is done, previous history of any surgeries,
Okay.
and also want to see if he has any regurgitation or reflux symptoms in the past.
Okay.
And that's all, sir.
Okay.
Okay.
Go ahead. Yeah.
His personal history, he is currently able to tolerate only liquids, and he is a regular BD smoker for the last 20 years. I just want to know whether he has stopped smoking, and if he has stopped, when he has stopped smoking. And his family history, there was no family history of any malignancies. And
So what do you
summarize,
think? The BD smoking is associated with your anything to do with this history or not?
sir, smoking is a risk factor for gastric malignancy, sir. And it's a risk factor for gastritis also. But it's so
Smoking is a
since
risk factor for gastric cancer, or
it is a risk factor for gastric cancer, sir.
which gastric cancer, proximal or distal?
The distal intestinal type smoking is a risk factor, sir.
Are you sure? Smoking is
Sure.
associated with distal type of gastric cancer. Smoking or alcohol?
Alcohol,
I think
which
it's
one?
alcohol. So
Sir,
please check. It is not smoking which is associated with the distal gastric cancer, which is causing gastric outlet obstruction. It is alcohol. Okay,
I
alcohol.
think
Okay,
esophagus has an association, but not stomach.
not stomach. Right?
okay, sir. Okay, sir.
And what type of family history do you want to know? Is any association of gastric cancer or something that is gastric outlet obstruction with family history?
Sir, the diffuse type of gastric cancer has family history, sir. Family history of stomach cancer in anybody less than 50 years of age, and family history of lobular breast cancer, and family
No,
history
the
of
patient is male. I guess is his male
yes,
patient,
yes, sir.
and
Yes, sir.
47-year, is a relatively young patients. So,
Mhm.
which type of family history do you want to know about in this case?
Family history of Lynch syndrome, sir. HNPCC, they have association with gastric cancer, and family history of
It is HNPCC or FAP?
so both as associations, sir. FAP is less because and HNPCC is 1 to 3% association is there, sir. And HNPCC is intestinal type uh, gastric cancer association is there, sir.
Okay, proceed.
Yes, sir.
Next.
This is my summary of the history, sir. 47-year-old former.
Just a second. Just a second.
Yes, sir.
Yeah.
One slide before, please.
Yes, sir, please.
See, in the diet, you have to elaborate on the patient's diet history over the years. Patient
Yes,
is
sir.
currently preferring liquid diet, or that's not in this personal history.
Yes, sir.
So what are all the diet risk factors? You will ask him in detail about the diet and this patient's history.
Yes, sir. History of salt and salted and smoked foods, sir, and increased amount of nitrate foods rich in nitrosamines and less amount of fruits and vegetables. And yes, sir. Smoked
Yes,
food and foods preserved in salt and
yeah,
yes, sir.
that should be in detail. This is special patient is currently preferring. It's not current. Actually, it's
Yes,
also
sir.
detailed. Okay, next slide, please.
Yes, sir. Is a 47-year-old farmer smoker presented with complaints of mild intermittent epigastric pain, which is aggravated by fasting, and postprandial vomiting containing partially digested food particles with increasing severity over the last 3 months, associated with loss of weight and significant loss of appetite and significant loss of weight. He also had one episode of small volume bloodstain vomitus accompanied by melena 15 days ago with no history of blood transfusion with no other significant past history, sir.
So what is your differential diagnosis?
Because of the short duration, I want to consider a malignancy stomach as the first differential, sir. And the second is a benign cause. It could be a peptic ulcer disease with gastric outlet obstruction. The rarer things that I have in my mind are could be a malignancy from GB causing obstruction or a malignancy from pancreas uncinate process causing obstruction, or it could be a chronic pancreatitis with pseudocyst causing obstruction. But these are rarer. I have kept in the back of my mind, sir.
What do you think?
What-
What is more common cause of gastric outlet obstruction? It is benign or malignant in India?
In India, now it's malignancy, sir. It was benign, and now the incidence is more of malignancy causing gastric outlet obstruction.
But you consider in this patient only malignancy because of short duration of symptom, not due to frequency
Sir,
of review. You
sir,
told
another-
that I
yes, sir.
consider
One more-
malignancy only because of that weight loss and short duration of
Yes, sir.
symptom.
And
It is
one more,
common here.
yes, sir. One more symptom, sir. He's got loss of appetite. The loss of appetite is more seen in malignancy and than in a benign. So that is also one point that I considered malignancy. And blood transfusion, he has received one volume, small volume bleed. Usually benign peptic ulcer bleeds will be large volume. They may have hematemesis. This malignancy bleeds will be small volume. It is a small trickling of blood from the tumor. That was also one point which I was thinking.
Why your first diagnosis is stomach malignancy? But you also told that there are other malignancies.
Other malignancies, yes, sir.
Yes, like pancreatic cancer and gallbladder cancer, right?
Gallbladder cancer, yes, sir.
And patient is 47-year male with a smoking and history of pain abdomen in epigastric region. Then why
Yes,
could
sir.
not be pancreatic malignancy? Why you're considering stomach malignancy as a first differential diagnosis?
Yes, sir. Because this it can still be a pancreatic malignancy also. So because of this bleed, one episode of hematemesis and more of a luminal
Which type
symptoms
of
like
malignancy is common in India? It's pancreatic or gastric?
gastric is common in India, sir.
Then just first say gastric malignancy is more common in India
Yes, sir.
presenting with gastric outlet obstruction rather than pancreatic malignancy. Although this patient has epigastric pain, but this can be with stomach cancer also. But also
Yes,
is giving history of bleed, upper GI bleed, right?
Yes, sir.
So these are the things that are suggestive of stomach cancer rather than
Yes, sir.
pancreatic or gallbladder malignancy, right?
Yes, sir.
Okay. Next.
So shall I proceed with the examination, sir?
Yes.
Yes, sir. He's conscious, well-oriented to time, place, and person. His DMI is 21, and he's moderately built and moderately nourished. His performance status is 0, and his vitals are stable, and he did not have any pallor. There's no icterus, no fetal edema, and there was no signs of dehydration or malnourishment seen, and no enlarged left supraclavicular nodes.
What is ECOG 0 status?
So ECOX 0 status is a patient who is able to do all his activities and he is able to even do strenuous activities, sir. There's no limitation of activity.
What about symptoms?
Sorry, sir.
Does his symptoms are limiting his activity? Does he
No,
have a
sir.
clinical symptoms which are very
So the
significant?
symptoms are
Is it called
not limiting his activities. That's why it is 0 there.
very
How can,
unlikely?
how can you explain no signs of dehydration or malnourishment in a patient with gastric outlet obstructions, 8 kilogram weight loss in such a short duration of time?
Sir,
Do you
I
agree that there is no signs of dehydration or malnourishment? Or there are some factors that leads that is in history that is there is no signs of dehydration or malnourishment. Why it is this?
Sir, I'm not able to explain this point, sir, because I expected him to be malnourished, but the examination
What do you
points
think? Maybe the patient is admitted already in IV fluid and has to
yes,
in
sir.
place
He
or in PPN.
yes, sir. I
You can
think
explain like that.
yes, sir. I think the next slide shows that patient has a Rayleigh tube. So
Yes.
he is
No,
admitted
no,
and
no, no. This next slide is in the rice too. But if I ask you what why it is no signs of dehydration or malnourishment, then you should be able to tell that the patient may be admitted on IV fluid, on Ryle's tube. So his dehydration part has been taken care of, right?
yes, sir.
Okay.
Yes, sir. I'll
Next
proceed to
slide.
the next slide, sir. And on abdomen examination, as the abdomen is flat with umbilicus is central in position and inverted, there is no visible scars, sinuses, peristalsis, or engorged veins. This hernial orifices and genitalia appear normal, and there is no visible peristalsis seen. Ryle's tube is noted in situ, and it was draining clear fluid, and around 200 ml is there on the back. His palpation, abdomen is soft and non-tender. There's no mass palpable. Liver and spleen are not enlarged. At the hernial orifice, there is no puff impulse. On percussion, the liver span is 13 centimeter in the right midclavicular line. And there is no flank fullness. The flanks are tympanic. This
Anything else you want to do in palpation and that percussion part in gastric outlet obstruction patient to confirm?
we can do in we can do two tests, sir. One is in patients with obstruction, we can do succussion splash that will demonstrate an enlarged stomach. Other one is the ausculto percussion technique, wherein we can mark the distended stomach, sir.
So is it relevant in this patient or not?
This patient has a Ryle's tube, sir. Already it is kind of decompressed. So we may not get that test positive. For succussion splash, patient has to be on fasting for 4 hours and then only we'll be able to demonstrate.
Right.
Which obstruction usually you get these signs positive, whether it's in a benign or malignant?
It is seen in benign, sir. Benign peptic ulcer disease.
Why so?
Because it is long-standing duration, sir, and the stomach distensibility is not affected in benign, whereas in malignancy it affects the distensibility of the stomach also.
What are the other tests that confirm it is gastric outlet obstructions?
From the history, patients can have
not history. Just
yes,
you have told auscultation that the auscultation.
yes, sir. Other one is if we can see visible peristalsis.
Patient is in Ryle's tube, then
yes, sir.
what type of you can confirm that it is a gastric outlet obstruction?
It will be a non-bilious fluid draining, sir. Even this patient has a clear fluid
What
draining.
can you do actively to confirm it is a gastric outlet obstruction?
That I'm
because
not sure,
200 ml of gastric fluid is there in Ryle's tube, then any test in previously used to do, and it is still relevant to confirm it is a gastric outlet obstruction, because patient came to you with Ryle's tube. You cannot do that suction splash and this type of thing to confirm. Huh? That, but still one thing you can do. What is that test?
I'm not sure, sir.
You know, saline load test? Saline load test?
Yes, I've heard about it, sir, but I don't know.
Just put 700 of a normal saline through Ryle's tube, and after half an hour, it is, if it is more than 400 ml, then it is suggestive of gastric outlet obstruction.
Yes, sir.
Patient is in Ryle's tube. and it is
Yes, sir.
draining 200. You cannot do suction splash and other thing to confirm the diagnosis. Then in
Yes,
this
sir.
patient, it is relevant to do saline load test. Although very few people do nowadays, but you should know this is
Yes, sir.
this which is called saline load test.
Yes, sir.
Okay, that can confirm that patient is having gastric outlet obstruction, right?
Yes, sir. Yes, sir.
Okay.
Sir, I'm not able to hear what
Yeah,
Anand
is
sir is saying.
VGP possible in malignancy? Is gastric cancer?
It was less likely seen in gastric cancer, sir, but can still be seen
Still
if
be
it's
seen,
a
yeah. In what
yes, sir.
scenario? What scenario?
If it's a small growth in the antropyloric region, occluding, then can be seen, sir.
Yes, we still do see VGPs.
Yes, sir.
Please proceed.
Yes, sir. Is digital rectal examination is normal, sir. Yellow feces, there's no melena. Is respiratory system and cardiovascular systems are within normal limits. There's no abnormalities. His CNS is
Respiratory
also
system, CPC and CN is normal. Okay.
yes, sir.
Next.
Summarizing my history uh, and the examination, sir. He's a 47-year-old farmer. He's a smoker and with a good performance status, presented with complaints of mild epigastric pain, which is precipitated by fasting, associated with postprandial vomiting containing partially digested food particles, with loss of appetite and significant loss of weight, associated one episode of bloodstained vomiting. And on examination, he was moderately built with a BMI of 21. His aeration status was fair with a Ryle's tube in situ and unremarkable general abdominal and systemic examinations. So there's no positive examinations.
So what is your differential diagnosis now?
Sure. Now, I still want to consider the same which I've considered in the history, sir. One is the malignancy of the stomach with the gastric outlet obstruction. Other one is a benign, sir. Examination wise, there's no palpable mass in the liver.
Benign case, you just only want to consider peptic ulcerations, not any other conditions. What are the other conditions which can cause gastric outlet obstruction?
It can be a corrosive, sometimes corrosive ingestions can also cause pyloric stenosis, sir.
Yeah.
History is not there. And other benign causes could be a pancreatitis with a pseudocyst, or a chronic pancreatitis with fibrosis can cause gastric outlet obstruction. And
So past history was also important regarding
important,
pancreatitis.
sir.
Frequent attack of pain, which is suggestive of subacute pancreatitis, leading to gastric outlet obstructions or chronic pancreatitis type of pain, right?
Yes, sir.
And what other malignancy can cause gastric outlet obstruction apart from gastric adenocarcinoma?
E- Even gastric lymphoma can cause outlet obstruction, sir. And if there is an endophytic gist, that can also cause obstruction, sir. Gist is often extrahepatic, but sometimes if they arise from muscularis
Other than gastric,
Is it
no, other than gastric adenocarcinoma, lymphoma, gist, what other type of malignancy can produce gastric outlet obstruction? And pancreatic cancer and gallbladder cancer, you already stated.
yes, sir.
Apart from that,
It could be from a retroperitoneal lymph nodal mass compressing the extensive compression due to a lymph nodal mass in lymphoma, or it could be a large liver mass compressing the extensive compression.
more important, more common, it can be duodenal mass,
Yes, sir.
duodenal mass, periampullary tumor, large periampullary tumor. These are
Yes,
also
sir.
the causes of gastric outlet obstructions. Not only
Yes,
pancreatic
sir.
malignancy, but duodenal cancer, periampullaries, large periampullary tumors. These can also cause gastric outlet obstructions. You have to keep in mind all these things, not only stomach cancer.
Yes, sir.
Okay.
Can
How will you
you
proceed?
can you explain? See, we need to discuss a lot about the pain aspect in this case. How do you
Yes, sir.
explain the pain when there is no mass? Is there? You said how do you explain the pain in this? You don't feel a mass clinically. What could be the cause for the pain?
So it could be a gastric ulcer causing the pain, sir. And or ulcer
If
could be
not gastric ulcer, still it is a malignancy. What could be the cause for pain? He says epigastric pain.
yes, sir.
How do you explain that?
Involvement of um, lymph nodes and penetration through the muscularis layer involving the peritoneum that can explain pain, sir. I mean,
Gastric malignancy may have ulcers, no? And that
yes, sir.
gastric ulcer can cause pain, then gastric malignancy can also cause pain
Yes,
due
sir.
to similar reason. Eh?
Yes, sir.
It is not penetrating into retroperitoneum. That will cause pain in back region. Eh?
Back region.
Then if
But-
it is a, no, if it is a very locally advanced, I understand that they may have a back pain or severe pain because of infiltration of the nerves. This is a small tumor where you are not able to find the clinical mass. Still patient complains of pain. How do you explain this pain? What can cause pain in such scenario?
So this
No, if you pass an endoscope, you find so many findings in an outlet obstruction of 3 months
yes, sir.
that could cause pain. What are all the causes of pain? What happens when there is a chronic stasis in the stomach because of malignancy obstructing antropyloric region?
There's a lot of food residue and stasis can cause inflammation. Sir.
Only inflammation?
It can cause erosions.
Yeah, it can cause a lot of erosion. Even stasis ulcers can come. What is the other issue? It is epigastric pain. If you go into the history detail, they will have retrosternal burning pain also. Why?
Not sure about that.
Because of regurgitation, you know, there's a chronic obstruction.
Yes, sir.
They will have regurgitation, vomiting, keeps on vomiting and retching, you know. Sometimes they may come up with hematemesis because of mucosal traps in the OG junction. No, those things you should keep in mind. Yeah, please proceed.
Yes, sir.
What is the common pathophysiology, pathogenesis of distal gastric cancer?
Sir, it is one is environmental factors, sir, seen in low socioeconomic status and associated with intake of salted and
What is more common in India? And how it
another
is
thing is
different from proximal?
H. pylori.
Yes. H. pylori may cause gastritis, and this may cause epigastric pain, recurrent epigastric pain for many years. Huh? So
Yes,
one of the causes of this epigastric pain, which is mild in nature, is maybe due to H. pylori gastritis, right?
Yes, sir. Yes, sir. Possible, sir.
Okay. How will you proceed?
Yes, sir. So first, I want to resuscitate the patient, start a line, and hydrate him. Then I will send initial blood investigation, sir. Do a complete blood picture and renal function
What type
test.
of abnormality do you expect, and what type of hydration do you want in this patient? And what type of investigations you will initially order after admission?
Sir,
Will you admit, or will you admit these patients, or you will and do investigation in outdoor basis?
So he needs admission, sir.
Okay.
And
how will you how will you resuscitate these patients, and what type of investigation initially you want?
Initially, I will want a complete blood
Yes.
picture along with a renal function test, sir, which includes sodium, potassium, and chloride and urea creatinine, sir. And then I will start hydration to this patient, sir. They'll have hypokalemic, hypochloremic. Sorry, sir.
Yes. Proceed.
Yes, sir. They'll have hypokalemic, hypochloremic metabolic alkalosis, sir. So I will correct them with ANS with potassium correction, sir, initially. And based on the results.
Is it true? You will start with the DNS and potassium from initial
Sir,
part.
Based on the results, I will decide my IV
So what is it?
regime.
You will give, if it is a hypokalemic metabolic alkalosis, right? Then
Yes,
you will start with DNS and potassium supplementation in the same time.
So I'll wait for the results, sir. I can start him with a free 5% dextrose to start with, sir. And then based on the results,
What
I
is
will add.
pathophysiology of this electrolyte abnormality?
Sir, sorry, sir.
Why
What
it
is
is hypokalemic metabolic alkalosis? What is the pathophysiology? What is the pathogenesis of this? Why it happens?
Yes, sir. Sir, is loss of hydrochloric acid from the stomach, sir. So in
Not only
in order
hydrochloric
to
acid, but lots of volume also. That
volume also, sir.
dehydration. Huh?
Dehydration, sir. And
So
in order
the
to
first thing you want to do is volume resuscitations by normal saline.
yes, sir.
Only thereafter you will correct potassiums. Not initial phase of that you will correct with DNS and potassium. It is common
Yes, sir.
teaching. Na? It is a volume contractions. The
Yes, sir.
main pathogenesis is volume contraction due to
Loss
recurrent
of fluid, sir.
loss of fluids. So first
Yes, sir.
thing is volume corrections by normal saline. And once volume is corrected, then you can give potassiums, not DNS with potassiums in the initial phase, right?
Yes, sir. Yes, sir.
But this is blender. Huh? You should know what is the actually pathophysiology behind this. Huh?
Yes, sir.
Okay. So what are the blood investigations? Can you
Sir, complete blood picture, renal function test. I also want to do a liver function test and bleeding parameters, sir. Prothrombin time with INR. After this investigations, I will.
what about
proceed
blood? Just
Yes.
there is so what the blood investigations?
this hemoglobin is 11.7, sir. And this total counts and platelets are normal, sir. 6,200 and 2.6 lakhs.
What is
Renal
RFT?
is urea is 18, sir. Creatinine is 0.7. And sodium potassium chloride. Sodium is slightly on the lower side, 133. Potassium is normal, sir, 5.1. Chloride is also okay, sir, 97.
Potassium is slightly in higher side. Why?
Slightly higher side, sir, 5.1.
Why so?
Um, I'm not able to explain, sir. Maybe because
You are
I'm not
Painting on rice tubes.
hypokalemic metabolic alkalosis, but here potassium is in high side, 5.1.
yes, sir. I'm not able to
Anything
explain
to
this,
explain?
sir.
The patient is on rails tube.
Yes, sir. Maybe he has had a
with fluid corrections and electrolyte imbalance correction.
sir. I'm not sure when this was taken. I presume this was
Yes.
taken before the resuscitation. Maybe
Why you are not sure? You tell the patient is already admitted on RAS tube already.
Admitted, no, on rails tube means somebody would be treating the patient.
Already
Yes,
treated the patient. So you should be very clear about that. Yeah? You are
Yes, sir.
expecting potassium, low potassium, but this is already admitted patient on RAS tube and already
Yes, sir.
in IV fluid. So that's why potassium is 5.1. And
5.1.
initial stage, there may be hyperkalemia also because of dehydrations or the low sodium lead to potassium shifting into extracellular space. But not in this case because already in this is admitted patients. Okay, next
Yes, sir.
investigation. LFT. What is the LFT report? What do you want to see in LFT report? Why it is
LFT,
relevant?
it is to assess his nutritional status, sir. His albumin, because he's chronic malnourished for the last it's quite significant weight loss, sir. 3 months, more than 10% weight loss.
Anything else? Anything else?
And it will also give us an idea if there is any biliary obstruction also, sir. Since we are
Biliary obstruction. Why biliary? Why you are expecting biliary obstruction in this case? Is partial gastric outlet obstructions, no history of jaundice.
sir, in patients, since we were considering two things, sir. One is pancreatic malignancy could be one of our rare causes. And the other one is if there is a CA stomach with a lot of nodes in the HDL, that can also cause some biliary obstructions. That is
So
just to
you want
explain.
to exclude some biliary pathology or gallbladder pancreatic pathology or some metastasis that may lead to some elevation of SGPT, OT or alkaline phosphatase, right?
Yes, sir.
So
This,
next investigation.
LFT wise, this albumin is low, sir, 3.3. Even the so suggestive of his nutritional status is poor, sir. And his INR is normal, 0.94. Prothrombin time is in the normal range. And I want to, after this, I want to proceed with the upper GI endoscopy, sir.
Upper GI endoscopy.
Yes, sir. Yes, sir. It shows a
So,
large
so
irregular.
stomach.
Yes, sir. Stomach is showing large irregular ulceroproliferative growth involving the mid and distal part of the body with partial outlet obstruction. They were able to enter the duodenum normally, and D2 is normal. So it is a growth involving the body of stomach with partial gastric outlet obstruction. Biopsy is
So this is common or what? So anything you find uncommon in this patient, it is not in upper,
yes, sir.
not in
The
G
history.
junction and upper, it is not in antropyloric, but it is mid part of body.
Yes, sir.
So what type of difference you want to look in these patients and why it is so? Any idea about it? Some recent papers are coming regarding that young patient in mid body tumor, not antropyloric, not G junction tumor.
That I'm not sure about that.
Are you aware of some papers like genetic? You just see that some papers are coming out in this in 40s and 50s. Some genetic predisposition, genetic linkage are there in because this type of tumor, 40 and 50s, we are most commonly in body tumor, not in antrum or not in G junction tumor. This is different sort of tumor. This is a diffuse type of tumor and having aggressive behavior, right?
Yes, sir.
Anything else you want to see in upper GI endoscopy, or it is sufficient? It's okay then.
I think this is okay, sir. Because the proximal extent, I mean, that is where it is starting from the GE junction that I just have to see. But this
biopsy is not
fine.
taken. I think in this report, it is written only findings are there.
Yes, sir.
You want biopsy or
Yes, sir. I want biopsy, sir.
how many biopsy?
There will be 6 to 8, 6 to 8 biopsies, sir, with the standard biopsy process. And this biopsy is reported as
And
poorly
what expect from that biopsy report?
So it's a poorly differentiated malignancy with signet cell morphology. They also have mucin pools extracellular, and so it's a high grade malignancy.
What are the WHO classification of biopsy? What is the pattern? What should pathologist point out? What are types of biopsy you are looking for? If you are looking the report of biopsy after upper GI endoscopy, what things you want to see, and then you can this can guide your treatment plan or prognosis.
Yes, sir. One is it the intestinal type and the diffuse type? Intestinal types will have gland formation, and the diffuse
So
type.
you told me that it is a signet ring cell morphology. Huh?
Yes,
Apart
sir.
from signet ring cell, what different types of pathology do gastric cancer have?
So they'll have
According to WHO classification.
be a well differentiated adenocarcinoma, sir.
No, it is not like that. Huh? It is mucin secreting or not mucin secreting. It is tubular papillary, right?
Oh, yes,
So
sir.
based on these things, you can investigate further. Huh?
Yes,
it is
sir.
one thing is just clear in this patient. It is signet ring cell morphology. Other things are it is whether it is mucin secreting or not mucin secreting, right?
Yes, sir.
Whether
Yes,
it is tubular papillary. These things are important.
Yes,
and
sir.
these are fully differentiated adenocarcinoma. Anything you want to add in this to get more knowledge from this biopsy?
Sir, since it's we can do
It's a young patient body tumor, poorly differentiated tumor with signet ring cells. All are bad prognostic factor. Huh? Do
Yes,
you
sir.
want to add something?
We can do immunohistochemistry, sir, for
Yes. Yes.
MSI.
What do you want to see IHC in this patient?
IHC for we can do for mismatch repair proteins, sir. MSI, whether
One is
lower
MSI.
MSI, sir. And
One is MSI. Other?
yes, sir. Other things we can do
Now it is
If
standardized.
you're considering
HER2,
therapy, we can do HER2 and PDL1, sir.
HER2, MSI, these two
And
things are mandatory, right?
mandatory, sir.
In this
Yes,
type
sir.
of the patients with particularly poorly differentiated adenocarcinoma with extracellular mucinous pools are also noted. Mucinous and signet ring cell morphology is there. So all the high risk factors are there in these patients. Huh?
Yes, sir.
Gilbert,
Yes, sir.
you have seen the endoscopy finding and you have the symptoms for this patient, and your biopsy comes as some atrophic gastritis now, chronic gastritis.
Yes, sir.
What will you do?
Sir, then I will consider doing a repeat biopsy, sir, because the endoscopy clearly shows a ulcer-proliferative growth. So I'll do deeper biopsy, sir, repeat biopsy, sir.
Okay, what are the adjuncts you can use in while planning a biopsy on endoscopy?
We can, in order to find the abnormal
Especially if you don't have a
areas,
mucosal, you are seeing some loss of rugal pattern, some infiltrated pattern, and no
yes, sir.
clear
We can
ulceration. What will you do then?
US guided biopsy, sir, deeper biopsy, endoscopic ultrasound guided deeper biopsy can be done.
Okay, Gilbert, next, what will you do? So time is running, only
Anything
15
else?
minutes.
Yes, sir. So I will want to get a chest X-ray and ultrasound abdomen first, sir. Now I've confirmed my diagnosis. I want to stage the disease. Initial set of investigation, I'll do chest X-ray and ultrasound abdomen, sir.
Is that the practice you do?
Sir,
Why do you want an
Chest X-
ultrasound at this stage?
sir, if the patient has ultrasound will look mainly for any evidence of metastasis, sir, disseminated disease in the abdomen. And chest X-ray also is to mainly to look for metastasis to the lungs, sir. And if the patient has metastatic workup, then the intent of treatment becomes palliative. Then we will not be
What
proceeding
is
with
actually
Then you would
recommended
not
and
do
what
a proper standard investigation in that case? Staging investigation?
sir, it will guide us to do the next test, sir. If
How
Gilbert,
come?
now
yes,
your
How will
diagnosis
it
is confirmed. Gilbert, your
yes,
diagnosis,
sir.
it is a poorly differentiated mucinous cell, signet ring cell tumor. Huh?
Adenocarcinoma. Yes,
And
sir.
with gastric outlet obstructions. So you have to
Yes,
do
sir.
something in this patient. So what is recommendation? Basically, we want to know what is the staging procedure. Still, you want to go for chest X-ray, ultrasound, or directly you want to go for CECT chest and abdomen that will solve all of your problem in
Sir,
one.
sir, I
Because
will.
if ultrasound is showing that liver metastasis, but patient is still having gastric outlet obstruction, then you will say the patient we cannot do anything. It is a metastatic disease, or you will do something for that patient.
Sir, I will first
So
do
only what
the.
you take. I'm not asking. I'm not telling it is wrong. It's just X-ray ultrasound is okay. It is a cheap investigations and you can do it easily and you can rule out metastasis. But what is your view?
Sorry, if there is extensive meds in the chest X-ray and ultrasound, then I may not proceed further, sir, with a
Are you
cross-sectional
expecting?
image.
Are you expecting in this patients based on history, physical finding, there is
No,
no
less,
ascites, abdomen is
less,
soft, I'm like normal, and no lump is palpable? Then why you want to look ultrasound for widespread metastasis like ascites or omental deposits or like that? You are still considering it as a resectable tube because there is no signs of any dissemination except that no albumin is there. There is no signs of ascites and nothing like that.
sir.
Do you still consider chest
It's
X-ray
a,
ultrasound rather
sir,
to
it's
deal
a
out a
large,
CT scan?
it's a large ulcer-proliferative growth, sir, in the
No,
endoscopic
based on
image.
your history and physical finding, that is also important. You
Yes,
have
sir.
already spent so much time in your inspection, palpation, auscultation, and you are just omitting all these things, and still you're suspecting that the patient is having ascites or massive. Okay, what is
Or
in
if the ascites picks
what
up
is
some mild ascites, would you consider it as a contraindication for further imaging?
No, sir. If there's
Some
mild
mild or
ascites,
moderate ascites in this patient?
no, sir. I will proceed with the cross-section imaging because he's got hypoalbuminemia
ultrasound
also.
finding is there, and there is no ascites, right? Only
Yes,
stomach appears dilated and presented with the food particles may say outlet obstruction. It had not added anything to your diagnosis.
sir.
And
Yes, sir.
next chest X-ray, if there is chest X-ray is no signs of metastasis. Okay. Then what will you
Okay,
do?
sir, I will do
Next.
a cross-sectional imaging, sir. Contrast enhanced CT scan of the thorax and abdomen and pelvis, sir, with a negative oral contrast and IV contrast, sir.
Thorax and
Thorax, abdomen, and
no, no,
pelvis,
no.
sir.
Thorax and abdomen
Yes, sir.
and
Thorax,
pelvis.
pelvis, sir.
Okay.
Can you show me CT scan?
Yes, sir.
You have controls over Gilbert.
Yes, sir. 1 second, sir. This is the
So read.
yes. This is a axial cut, sir. It's a non-contrast image starting from somewhere at the mid-thorax at the level of heart. So
Go.
I'm moving.
So what is the chest finding?
The chest, this I have not put the lung window, sir. In this,
Okay.
I'm not able to see any. I mean, I have to put it in the
Window, there is
lung.
no sense.
In this window,
No
there is
pleural
no
effusions, no.
pleural effusion also, sir. It's a distended stomach along the lesser curvature. I'm able to see a large, the entire
This is
stomach.
non-contrast.
Non-contrast, sir.
Imaging.
This is non-contrast
So
imaging, sir.
what do you want
But
to see non-contrast? You can order something portal venous page of us to characterize tumor. What are
yes,
the
sir.
findings
Shall I?
you want to see in non-contrast? Will
Sir,
you
in
describe
this,
tumor in non-contrast CT scan?
no, sir. I describe with a contrast, sir.
Then ask to show portal page.
I'll change the portal page, sir. This is the portal face, sir. And going to the abdomen, sir, we can just describing the stomach, sir. Along the lesser curvature, both anterior and posterior walls, somewhere from the mid body, there is increased wall thickness, and the stomach appears the increased wall thickness, and there's a mass seen, sir. And it is extending up to the. I'm not able to see the pylorus clearly here, sir. It is mainly body. It is mainly body and the antrum, sir. Body predominantly and less in the antrum side, sir. And the fundus area and the greater curvature area is free. The plane with the 1 second, sir. Let me just go up, and I'm able to see nodes, enlarged nodes along the left gastric area, and also in the just above the hepatic artery, also some few nodes are there, sir. And as we come down, there is one area. This area, I'm not sure. The plane with the pancreas is little doubtful, sir. As we come below, the planes are well seen, but above the plane with the pancreas is somewhere. It is not clear, sir. This area, and
what else?
I'm looking at the
or duodenum is free. So
yes, sir.
you don't know any doubt about duodenum. Pancreas looks like free except in the head region. There is minimal lymph node, not. And what are the findings you want to see in CT scan?
I want to see the liver, sir. Liver, I'm not able to see any hypotenuse lesion.
So liver is normal and there is no ascites, right? No mental deposit, no ascites.
Gilbert,
Yes,
on
sir.
CT scan, when did you say the lymph nodes? You have seen some lymph nodes there, no?
Yes, sir.
Are they significant, or what are the features of a metastatic node on CT scan?
Sir, if the node size is more than 1 centimeter and the shape is more rounded, and there is loss of the fatty hilum, they are in favor of a tumor involved node, sir.
What else?
Metastatic.
Node more than 1 centimeter or 8 mm? Yes. In
More
the
than 1
perigastric
centimeter.
region, is it 1 centimeter?
I'm
Okay,
not sure.
Anything
now
more
it is
than
8
6 to 8
mm,
mm
right?
is significant. Yeah.
It's great amount.
The
Okay,
next investigations you want to do in this case, because time is running out.
yes, sir.
CT scan now is a
Sir, I
summarize the
want
finding of
to,
CT scan. No, just
yes, sir.
summarize the finding of CT scan.
Sir, it's a large growth, sir, arising from the mid
It
body.
is resectable locally. It is a locally advanced CS stomach or
It is locally advanced CA stomach, sir, with no evidence of metastasis in the CT, sir.
So it is still resectable.
It
Do
is
you
the,
feel there is a direct infiltration? Do you feel there is an infiltration in the pancreatic head side, or it is just loss of fat plane alone?
sir, I am not sure, sir. I want to discuss with the radiologist because this area, it looks like there's
Can you
no
show
clear.
CT scan reports, please?
Yes, sir.
What is CT scan report? Because we think well cuts. Is CT scan report is available?
Looks like only the plane is lost, not
Plane is
infiltration is not seen.
No, sir.
Maybe if there is a detailed report, it's okay. Okay, please proceed.
Sir,
Okay, it is a locally advanced, but still, how will you proceed? CT scan is now it is a locally advanced. It still looks like
Okay.
resectable with gastric obstruction, low liver metastasis, no ascites. How will you proceed?
Okay.
What is your
this
investigation?
sir, this patient is for a neoadjuvant therapy, sir, because it's got mid body tumor.
And this
mostly
lesion is
differentiated.
it is written in CT scan. No. It is written in CT scan. This lesion is still abutting left lobe of liver, head, and body of pancreas. Right?
Yes, sir.
And a small lymph node is there.
Yes, sir.
Okay, what is your
So-
next plan?
So next plan is to, because it's got large locally advanced disease, he needs, the staging is still not complete, sir. We might have to do a PET scan as well as if
What
PET
is
scan is
sensitivity
also,
of PET scan in this case? In this case, and is it recommended by NCCN guidelines or other guidelines?
no, sir.
And
Actually,
it is indicated in the
sir, PET scan is less sensitive in mucinous tumors and signet cell tumors, sir.
signet ring cell diffuse.
Yes, sir. They are less
And is it
sensitive.
recommended in a distal
Then
gastric
why
cancer?
Then why you
Sir,
told PET scan in this case? This
So
entirely
because of this
entirely
large,
not indicated, particularly in this case.
such a large growth with doubtful.
No. What is
It's a T4.
this sensitivity? No. Albert, what is sensitivity of PET scan in mucin secreting tumor?
It's less than 30%.
It is mucin secreting tumor, na? So it
Yes,
is zero sensitivity.
Yes, sir.
Rather than doing PET scan, what else you want to do in this case
Yeah,
before
will
starting
do a-
neoadjuvant therapy?
Yes, sir. Staging laparoscopy for this patient, sir, and a peritoneal cytology.
That's staging laparoscopy is more relevant in this case, not PET scan.
Yes, sir.
PET scan, you should not commit that. Basically, it is very clear. It is mucin secreting, and all know that mucin secreting stomach cancer PET scan is not indicated. Even in NCCN guideline, PET scan is not indicated. So you should proceed with the diagnostic laparoscopy. Why diagnostic
Yes, sir.
laparoscopy? Why don't you want to do directly for neoadjuvant chemotherapy? And patient
Sir,
is also having gastric outlet obstruction. Want to do anything for the gastric outlet obstruction?
Yes, sir. When this patient, when I'm planning to do the diagnostic laparoscopy, sir, I will consider doing a feeding jejunostomy for this patient, sir.
Yeah, what is the
Because
rationale? What is the rationale of doing diagnostic laparoscopy in this patient?
just to
Some
see if
therapeutic-
to see if there is any intra-abdominal peritoneal metastasis, sir. Because
yes.
less than 6 millimeter, less than 5 millimeter deposits will not be seen with a CT, and 2 millimeter deposits can be seen with staging laparoscopy.
So you want to do diagnostic laparoscopy prior to neoadjuvant to rule out metastatic disease,
Yes,
right?
sir. Yes,
So
sir.
if there is no metastasis, say liver is normal, there is no mental deposit, then
Yes,
you will that will miss diagnostic laparoscopy, or you will want to do
We'll
something.
do a peritoneal lavage, sir. 500 ml saline will instill, and then we
If
will.
peritoneal lavage is positive, then what will you do?
Then it becomes a metastatic disease, sir, M1 disease, and we will establish a feeding process for him.
It is
during
now
that
confirmed that it is M1 disease or there is controversy regarding that. If it's diagnostic, if it is peritoneal lavage is positive, otherwise there is no signs of
Sir.
metastasis. A young patient.
So if the peritoneal lavage is positive and there is no obvious peritoneal disease, These patients can be given chemotherapy like a neoadjuvant setting for 6 months and can be reassessed if the cytology becomes negative and if there is no progression of disease, they can be given a chance of cytoreductive surgery. That is.
Do you want to do anything for gastric outlet obstruction in this setting, in diagnostic laparoscopy setting? You have ruled out malignancy,
Yes, sir.
disseminated malignancy.
Yes, sir. This is a large, bulky tumor, sir. So endoscopic stenting is not possible. I'll ask if there is a endoscopic nasojejunal tube placement. If it is possible, I'll consider nasojejunal tube placement, sir. If that is, if since I'm doing a diagnostic lab, before that I'll discuss. If that is not possible, I'll do a feeding jejunostomy, sir, along with the diagnostic.
Not gastrojejunostomy, only feeding jejunostomy or gastrojejunostomy also?
So only feeding jejunostomy, sir.
Why?
Because we have a curative intent treatment for the patient.
No. Patient is having tumor in body.
Yes,
how
sir.
will you do gastrojejunostomy in this case?
There's no place to do that.
No, there is no place to do that. That is a more important thing. Rather than you are want to do, the patient has tumor in body of the stomach. How will you do gastrojejunostomy in this case? You cannot do gastrojejunostomy in fundus, right?
Yes, sir.
So we will do feeding jejunostomy and then again go for neoadjuvant chemo.
Neoadjuvant
right?
chemo, sir.
Which type?
Yes, sir.
Which type of neoadjuvant chemo we do?
Sir, we are giving
What
flot
is
regimen.
your regime?
So we are giving flot
What is
regimen,
flot
sir.
regime?
5-fluorouracil,
What is
leucovorin.
flot?
That's what, sir. It is a 4-drug mnemonic, sir.
No, what is
5-fluorouracil,
flot?
leucovorin,
5-fluorouracil, then
leucovorin, and oxaliplatin and
what other?
docetaxel, sir. Other drug is ECF, sir. ECF is the magic trial which.
How many doses? How many doses you want to do in pre-operative? No. Just
Sir,
I want to know.
if
Flot
it's
you are giving flot
ECF,
is okay.
Flot
Then
is
how
4
many
cycles.
doses you want to do?
4 cycles before and 4 cycles after surgery, sir, in flot. ECF is 3 cycles before and
What
3
is the
cycles
problem
after.
of flot?
It is
No, I am not asking you about ECF. I am
yes, sir.
asking you about
Problem of flot is it is more toxic
what is the
regimen.
problems you get from the flot.
It is
Okay.
it is a
So many people cannot tolerate that flot regime.
flot
Huh?
regimen.
So
Yes,
ECF is relatively less toxic regime than, right?
Yes, sir. Yes, sir.
Then after 4 cycles of chemotherapy, same findings are there. Then what will you do?
Sir, if there is a non-progressive disease, sir, and a stable disease, then I will consider again plan for a surgery, sir. If it's progressive disease, then I'll explain the patient poor prognosis.
You will
If
do
it's
diagnostic laparoscopy this time, or you will omit that?
again,
Say diagnostic laparoscopy.
I will do
positive.
a staging laparoscopy again, and if the staging laparoscopy shows no peritoneal disease, then I will proceed with a radical.
And if it is still cytology positive, then you will abandon.
The second time, if cytology is positive means, then we will abandon, sir. Not sure, sir.
Okay. Okay. What type of surgery do you want to do?
So this patient, I think we'll do a total gastrectomy, sir, because proximal margin will be less. So we'll plan for a
Gastrectomy is okay.
How much proximal margin do you expect for a subtotal gastrectomy, distal radical or subtotal radical gastrectomy?
5 to 6 centimeters proximal. If you have to do subtotal proximal margin.
On the lesser curvature side, how much
Sir,
from the OG, on the lesser curvature side, how much on the OG junction you leave?
It is
you leave a cuff of stomach, no? How much on the lesser curvature?
That I'm not sure how much on the lesser curvature, sir. Around 20% of the stomach is
1 to 2 centimeters is sufficient in this neoadjuvant chemo radiation therapy, right? You are anyway you are going for total gastrectomy. So proximal margin you cannot get 5 centimeters. Then you have to remove this. But fundus is normal here. G junction is normal. You're just taking precautions, and you are because this is a body tumor, so you want to do total gastrectomy. And what type of lymphadenectomy you want to do?
Do a T2 lymphadenectomy, sir.
What is T2 lymphadenectomy? Just tell me what are the lymph node stations you want to remove?
Sir, station 1, 2, and
Just-
right and left paracardiac, 3, 4, 5, 6, suprapyloric, infrapyloric. Then along the left gastric artery, 7. Then along the hepatic artery, 8. Then along the celiac trunk, 9. Then I will, the station 10, no need, sir, because it's a lesser curvature tumor. Station 11, proximal, I will clear, sir. And station 12, along the artery, I will clear, sir. These are the.
Okay, then okay. You want to do D2 gastrectomy. And now histopathology came as a MSI high tumor.
Yes, sir. MSI
What
high
will you do
tumors.
next?
Them
Recovered
will,
well. Patient recovered well, and now histopathology came as MSI high tumor
yes, sir.
with deficient MMR. Then
Deficient MMR.
do you want to continue chemotherapy or what will you do?
So MSI high tumors, they do not, they are good, they have good response with immune checkpoint inhibitors, sir. So we can consider pembrolizumab or nivolumab for these patients, sir, rather than the.
You will not consider chemotherapy in this. Then continuation of chemotherapy. There is no advantage of adding adjuvant chemotherapy and MSI high, right?
Yes, sir. Yes, sir.
Okay, I think time is off. Dr. Shabeer, Dr. Laxmanan.
I think, Gilbert, you
Anything
discussed
you want
well,
to ask?
except you made some confusions with the PET scan and all. Otherwise, most of the things you have discussed.
Yeah, he did very well. Yeah, good. All points were discussed in detail.
Pradeep, sir?
Over
Yeah,
to you,
we can
sir.
ask other faculties to come in. I think probably you have done well, Gilbert. I will ask opinions from other faculty, Dr. Shastri, Dr. Kapoor, Dr. Supe.
Good morning, Pradeep. VK Kapoor here.
Good morning, sir.
I don't have much to add because I think most of the points were discussed by the moderators and answered very well, as everybody felt, by the student. So students, if you want to read a little more about CS stomach, please send me a mail, vkkapoor.india@gmail.com. Write stomach in the subject of the email. Thank you.
Dr. Shastri.
Yeah, I just wanted to add here, say your final assessment, it's a locally advanced growth, gastric growth, no metastatic disease, not much of nodal disease, and presenting with predominant symptom of vomiting and gastric outlet obstruction with a grossly dilated stomach. I think, say, upfront surgery is not completely ruled out here. Of course, you do a peritoneal lavage and cytology at the time of surgery for prognostic purpose, but the gastric outlet obstruction and predominant vomiting needs to be considered in the algorithm of management. I think this you cannot completely ignore. And following this, of course, you would give an adjuvant chemoradiation or a chemotherapy. That option, you should keep it in mind, particularly in distal gastric growths. It's not a proximal growth. There are a few other pointers, say, in the clinical profile. One is every postprandial vomiting is not gastric outlet obstruction, but particularly retention vomiting is not present. You can have gastric cancer presenting with an irritant vomitings of small pus with nausea and vague dyspeptic symptoms. That doesn't amount to gastric outlet. Benign duodenal ulcers have massive bleeds. You can have a oozing duodenal ulcer, what is generally considered as a Forest 1B. And then the other thing in the epidemiological changes these days, incidence of distal gastric cancer, the present case notwithstanding, is coming down. And pancreatic cancer can present, say 15% of them at least can present with gastric outlet obstruction, which you should consider in the epidemiological sense, in the clinical diagnosis. PET-CT, of course, is already pointed out. So these are a few things I wanted to mention. Otherwise, you have done fairly well.
Any other comment, Professor Supe? I think if there are, there is one question, I think in the question box, Shabeer or Anand can address that question.
Pradeep,
Q&A.
since there is time, I
Yes,
would
sir.
like all of us to guide the students as to what they should say and how they should defend this dilemma, whether to do a chest X-ray and ultrasound first or whether to go for cross-sectional imaging. So before the other examiners answer, my approach would be that in those malignancies where presence of a metastasis is going to drastically change the management plan, it should be mentioned. For example, HPB malignancies. Whereas in GI malignancies, and they are also upper GI is more important than lower GI, one may kind of directly proceed to cross-sectional imaging. Now, in this case, when it was asked, if I were the student, I would say that agreed that straight away a CT scan can be done. But if chest X-ray shows a metastasis, if ultrasound shows extensive metastatic disease, then I may not consider operating upon this patient, and I may consider a non-surgical option of endoscopic or radiological stenting as relief, palliative relief from gastric outlet obstruction. And then depending, because he is a well-preserved patient, give him chemotherapy. So surgery may not be on the cards. The only situation where it may not help is a colorectal malignancy, where irrespective of the presence of metastatic disease, one would still go ahead with resection. But there also, ultrasound has an advantage to find out whether there is any evidence of urinary tract obstruction in the form of hydronephrosis and hydroureter, for which ultrasound is a very good investigation. What would the other examiners advise the students to say?
Sir, I think I'm completely. So, but
Sorry,
it is actually institutional protocol. Actually, depends upon what is your institutional protocol. Sometimes, like in my institution, we have a period of around 10 to 12 days to get ultrasound. But a CT scan is more easier to do. And in this particular case, patient is having gastric obstructions and something has to be done. And NCCN, even NCCN guidelines not suggested that chest means to is if there. So CT scan in one go is an option, but it is not like that chest X-ray ultrasound should not be do. So in this type of class, okay, to say that chest X-ray ultrasound should be the first diagnostic modality, but in practical, we prefer to do CT scan, chest, abdomen, first go, because already patients come with the ultrasound and chest X-ray, which is a very poor quality and nothing add to the diagnosis in this type of cases after upper GI endoscopy confirmed gastric cancer. This is my takes.
Yeah, there is a question by somebody has asked a question regarding the signature cell and moderately differentiated adenocarcinoma, if it is an operable. See, this is very standard. You have to do a distal radical subtotal D2 gastrectomy by leaving an adequate 6 to 8 centimeter margin in an unstretched stomach. That is a standard. But when it is a node positive, like T3 node positive disease, you either choose at least 2 cycles. We call this as a sandwich therapy. As per the MRC trial, you can give FLOT regimen or ECF regimen as per your institutional protocol, and then do the surgery, then give adjuvant cycle of chemotherapy. The prognosis is much better.
Right.
Somebody wanted to add? Anybody wanted to add on this?
In signature cell type, it is aggressive and diffuse, so margin is more important. So we will go for total gastrectomy in this type of cases. Otherwise, in well deficient tumor, specifically in distal tumor, where 5 to 6 centimeter margin is there is no add that. Only thing, signature cell, because of diffuse nature, and mostly these are business tumor, more widespread margin and skip metastases are there. So in that case, total gastrectomy. Evidence centimeter is okay, but in the era of new adjuvant chemoradiation therapy, specifically for proximal gastric tumor, 1 to 2 centimeter is sufficient.
Dr.
And
Gilbert,
another question is, what is the role?
Dr. Gilbert, what is functional gastrectomy? Have you heard of this? Functional gastrectomy. Some Japanese papers are coming out with functional gastrectomies to improve the quality of life.
Sir, I'm not sure.
Functional gastrectomy.
Functional gastrectomy.
Sir, I'm not sure, sir. I've read about proximal gastrectomy.
Maybe proximal gastrectomy they're thinking about. Then another question is, what is the role of palliative gastrectomy in modern time?
Sir, if it's a uncontrollable bleeding.
You need not to answer. That's from other people. I'm just asking, what is the role of palliative gastrectomy in modern time? Is there any role of palliative gastrectomy? I think it is role if it is patient is having bleeding and it is not controlled by endoscopic measure like organ plasma coagulations or something like that, and still it is undetectable. Then there is still a role of palliative gastrectomy. Otherwise, in modern armamentarium, there is nothing like even bleeding can be controlled with endoscopic organ plasma coagulations and other things. Then you can, if it is resectable, then you can go for neoadjuvant. Then again, reassess about that. If it is a widespread metastasis in gastric artery obstruction, still stenting is possible. If at all, then gastrojejunostomy, I think, is better option rather than to go for palliative gastrectomy. Only indication of palliative gastrectomy in modern time is massive GI bleed and not amenable for endoscopic APC. Any other take? Anything you want to add, sir? Dr. Anand, Laxmanan?
No, I'm fine. I just that's all.
Another question is, does signet ring cell type warrant total gastrectomy in distal tumor? Another question is, Dr. Shabeer, you want to?
Yeah, in infiltrating tumors, this type of tumor where you have a good involvement of lesser curvature, very unlikely to get a good margin of more than 5 to 6 centimeters without a total gastrectomy, especially signet ring cell tumors. But if you have a localized disease, if and involving the greater curvature side and all, it may be possible in a small group distal tumors.
Okay. Yes. And other question, is there any protocol for cytology positive disease in carcinoma stomach? We already, I think, discussed in detail. There is still this is the controversial part, and no guidelines clearly say what should be done. Some consider cytology positive as a metastatic disease, but other locally advanced disease. If cytology is positive and there is no signs of distal metastasis like liver metastasis or peritoneal metastasis, then you can consider it as a locally advanced and first give neoadjuvant chemoradiation therapy. Thereafter, again, redo diagnostic laparoscopy, and in that time, cytology is negative, then you can proceed with D2 subtotal gastrectomy. But cytology positive in presence of some omental nodules and liver metastasis, then obviously it is a distal metastasis. So still, it is not clear that cytology positive. Otherwise, no distal metastasis is what to do. But these are the recommendations we have already discussed.
So if there are no comments, can we wind up, sir?
Yes.
Thank you, Gilbert. Thank you, Professor Shabeer Ali, Professor Utpal, Professor Anand Laxmanan, for an excellent discussion. Thank you very much.
Thank you, sir.
Thank you.